I'm pressing recording. Good morning. This is MED240 Pharmacology, 7DAX. It is now 9 a.m., Thursday, January 28th. And what is due today? Study questions, antibiotics in topic 3 and discussion 3. And what we're doing today is topic 4, antifungals and antivirals. And we're going to be focusing on HIV. And discussion 4, let's make discussion 4. Don't worry about this homework. Let's get rid of this because you guys have to study. So discussion 4, that will be extra credit. So I'll, if you want to do some discussion 4, that will be for extra credit. But hit up these, hit up this Principles of HIV Drug Therapy quiz. So just at least so we can be honest. All right. Another public service announcement is if you look at the very, very top, we now have tutor.com that's affiliated with Stratford University. So click on that if you need some help. Of course, you could still ask your professor. That's also a good source. But you know, hit this up, try this out. I'm going to try this out this weekend as well. I'm going to pretend to be a student and have some trouble and see if they can help us out. Because, and the reason why we're putting in a tutor.com is because many times some people ask me, can you tutor me at like 9 o'clock, 9 p.m. on a Sunday? Well, no, I can't. But tutor.com is 24/7. And a wide array of topics. Now, the midterm exam. So it'll be posted in Moodle announcements. So if you've had me before, you probably already know this protocol. Now, if you click on this midterm exam here, that is Dr. Cisco's version. That's her, she has an 80-item midterm exam, and it looks kind of like mine. But it's also good practice. And also I will be putting a practice exam as well in announcements as, you know, as usual, those of you who had me before as my protocol to help you guys out in studying. The format will be 50 items, multiple choice, week 1 through 4 topics. And I'll be going over those topics today. And also the due date for that is 10:15 a.m., same day. And I need an email to my email here, right? But just the answers. Please don't copy the entire exam. I just need, all I need to see in the body of that email is 1 through 50, A, B, C, D, or whatever, okay? And make sure before you send it that it is exactly what you send it. Every term, I always have somebody sending me a photograph of their answers or the entire exam with the answers circled in crayon. Please follow the directions. It'll make my life easier. I'm teaching 5 classes and 4 of them are lab classes. So I have a lot of grading to do next week. Okay. And of course, every minute beyond 10:15 a.m. will incur a 1-point penalty because, and why the time limit? Because in theory, it's supposed to be a closed book exam, but you know, you're on your own honor. But honestly, if you can quickly look up something, do so. The link above, oh, the link above, I already told you that. This link here, if you click on this, this is not the real midterm exam. This is Dr. Cisco's exam. Okay, so let me put Dr. Cisco's practice exam. I think it's 80 items. Just so there's no, and I'll put my an old midterm exam of mine, 50 items, in the what's the hoses? What do you call this thing again? Announcements. That's right here. Okay, so let's get this show on the road. Let's talk about some antifungals and antiviral. Now, last week we had a lecture on antibiotics. So antibiotics are for bacteria. So let's talk about these other fungi and fungal diseases. So these are the eukaryotes: fungi, mushroom, yeast, and mold, right? And they're usually due to either immunosuppression due to disease or extended drug therapies. And we already know that corticosteroids do a number on your immune system. Also, anti-drug or anti-cancer or anti-neoplastic medication also lower your immune system, right? Funny. Look up the COVID numbers on people with corticosteroids and anti-neoplastics. It's not increased. Isn't that odd to you? Odd to me. So something to think about, right? Again, I'm not here to tell because I'm only here to present facts to you. The rest, as a student, you have to try to do your own research and infer. But for the exam purposes, antifungal is only good for fungus or a yeast, right? Or a mold. Antiviral is only good for a virus, okay? So the mechanism of action is they like to, just like penicillins, they like to mess with the cell membrane. Because remember, like we mentioned last week, you poke a hole in the cell membrane, it's like poking a hole in your skin. The patient will bleed out, right? And there'll be no barrier, and then all fluids and items will go in and out, and then the fungus will die. Another thing that it does is funguses have these enzyme systems just like us. We also have cytochrome P450, right? Cytochrome P450 is part of our enzymes and metabolism in our liver, right? So if you destroy your liver or like something equivalent to your liver function and metabolism function in a fungus, you'll kill that thing too. And they have topical, meaning like creams, IV, of course, we put it intravenously and goes, and pills that'll be accepted systemic. It'll go throughout your entire system. So the two big mechanisms of actions is destroy the cell membrane, right? By preventing, remember if you recall, there was cholesterol or sterols inside your cell wall. Well, if I mess with those, it'll poke holes in the fungus membrane. So mess with the fungus membrane, mess with the cytochrome P450 system in your fungus, and they should die, right? Now, antifungals do not work on bacteria or viruses. That's why the diagnosis portion, as I've always stated, if you took my MED240, remember SOAP, subjective objective assessment plan. If your assessment doesn't work, your plan is useless. So if you misdiagnosed your patient to having a bacterial infection, right, and you give them antibiotic, it's not going to make them better, right? So pharmacology is only as good as the diagnosis that precedes it. Okay. Now, remember, it's set up here that cytochrome P450, right, is different from human cytochrome P450 and has little effect on human beings. No, that's kind of, Dr. Cisco should have erased that. Cytochrome P450, yes, it's different, but again, it is a metabolic function. And if antifungal medication mess with metabolics, it's going to mess with human metabolics. So there is a common side effect is some liver toxicity, especially if it's systemic. But if it's just topical and just, it's just a cream, then you should be okay. But, and that's why one way we fix that issue is we do what they call pulse dosing. Like I only give it like at the beginning of the month or every 2 weeks, that kind of thing, so that the buildup of the drug inside the human system isn't so bad. So let's look at some examples of antifungals. And let me say, these are the major categories. Echinocandin, triazoles. Now, if you look at, let's look at some common ones. This is how I always remembered. Like if I see like azole, that's it's, like fluconazole, like itraconazole. You can see there's azoles. That's already like half this list. And for the echinocandins, they're easy. It has the word fungus in it, right? Fungin. Okay, so use that. All right, as like a hint. But the antifungals that are really common is amphotericin B, clotrimazole, which is Miselex. Griseofluven is really popular in dermatology. Ketoconazole, Nizoral, you've seen the commercials. Nystatin, or mycostatin, right? And look, it has the word myco in it, okay? Which is fungus. This is another, remember, mycosis is abnormal condition of fungal infection. And another azole. And Lamisil, you've seen the commercials for that, is terbinafine. So Lamisil, Nizoral, mycostatin, grisofulvin, and amphotericin B, big time antifungals that you see on the market all the time. And use azole and fungin as like as a hint that we're talking about an antifungal. So here's some more, a little bit more details about these drugs. And remember, one thing you could do is you could copy and paste some of this stuff and then and make a flashcard. And if you see, I forgot to mention in the previous lectures, that is how Dr. Cisco made her PowerPoint slides. If you see these slides, you could probably print them out and then, you know, just take a scissor, cut them out, and then you could use them as, you know, as, what do you call that? Flashcards. So amphotericin B, really popular, right? Really good. It goes really good. It's a broad spectrum fungicide. That means it's a killer, right? And it's even kind of in its name, right? Fungicide, right? Side, SCI, right? But amphotericin B is really good. But if it's systemic, we already know that it goes not very good for your liver, and it has some toxicity side effects. Now, we use it. You need it. This is if it's in red, it's kind of important. Oh, I mentioned first line therapy, okay, for a systemic. And that's why it's so popular. Now, you need some aspirin, antihistamine, or acetaminophen because you got these side effects here: fever, chills, shaking, and it's just not pleasant. Now, black box warnings, right? You'll see like a little black box on the as a label, and just know that this is a pretty hardcore drug, and that's why it's going to have some side effects, and that's why you should take it with aspirin, or I don't like aspirin, I like acetaminophen, because remember we mentioned in our first lecture, aspirin's salicylic acid, it's a little bit too harsh on my GI. I like acetaminophen, it's a little bit better. That's why no one takes aspirin anymore, unless it's low dose, 81 milligrams per day for cardiac patients. Just as a little side note, aspirin has a, it thins out your blood a little bit, which is good for cardiac patients. Clotrimox, another broad spectrum, right? And it's good for mouth and throat. Okay, also comes in topical. And remember, I told you about I gave a suppository for my patient. Remember, the if it says topical, that means it should be in the area, right? So and you might even see this term lozenge, right? That means don't swallow it. You like a throat lozenge, you just keep it in your mouth and you let it melt. So lozenges, you don't you don't swallow them. You just you let it melt and slowly let the drug melt into your GI. But clotrimazole, broad spectrum, just like amphotericin B, but amphotericin B is some hardcore stuff. Okay, topical, ringworm, athlete's foot, grisafluven, right? It's nice. And you'll see that there's gonna be these labels. So if you see this label, right, that means it has some UV effects. So, and of course may cause dizziness and drowsing. A lot of stuff, but it's typically a topical. Athlete's foot, ringworm. Ketoconazole, Nystatin, right? It's black box warning again. Hepatotoxicity, okay? You got to watch out for that because of the cytochrome P450 effect. Mycostatin, also Nystatin. And remember, if it's in parentheses and it starts with a capital letter, that is its proprietary name, right, or brand name. The generic is the lowercase one without the parentheses, okay? And nystatin's, mycostatin's good. It's used for oral candidiasis. You get Candida albicans, and you'll see it. And a lot of patients who have, who take, those inhaler medications, they get oral candidiasis, and they have to like swish and swallow. They have to kind of gargle nystatin to deal with that. And it also can come in a topical. Terbinafine, Lamisil, very, very popular. It's used for fingernail and fingernail infections. So watch out for when make sure that when you go to a good nail place that they're up to code and they're clean, because remember, on your skin you have these little buggies. They're little bugs. They're called dermatophytes. Well, dermatophytes also, if it's not a clean place, under your fingernails and in between your fingernails, you can have onychomycosis, and we use terbinafine for that. Okay. Triazoles, we already know they definitely interfere with the cytochrome P450 system, and we know that's the suffix azole is in their name. So once you see fluconazole, itraconazole, which is azole, right? Sporanox and diflucan, really, really popular. You already know that that's an antifungal, okay? Fluconazole, oral and vaginal candidiasis. Again, I mentioned the mycotic agent Candida albicans, also known as thrush for oral, right? Maybe you've heard of that term. Itraconazole for nails, right? And you've seen that twice already. Fatty meals, right? Noxafil, I haven't used this too much. I use these more, Sporanox and diflucan, when I was practicing, right? But one thing that's cool about Noxafil is that it's a prophylaxis for infections for an immunocompromised patient, including HIV patients. But I guess even though I had a ton of HIV patients, I don't use this. Aspergillus is another kind of infection, and voriconazole, and I haven't used this much, and apparently it can be used IV. And you've seen this more than once, life-threatening fungal infections. A fungus can kill you if it gets out of hand, especially if you're an immunocompromised patient. HIV patients, they get fungal infections all the time. Patients who are on severe, serious anti-cancer medications, we watch them for fungal infections all the time. and I've had several patients succumb to it. Kind of candins, again, candida and aspergillus. Aspergillus is can be a nasty lower respiratory tract infection, and you can see it's IV. Caspofungin, all right, inhibit the synthesis of D-glucan, but don't have to memorize that. You know that it's what? Cell wall, because there's only two mechanisms of actions of antifungals. It's either cell wall or cytochrome P450. And what do we know? All the azoles is cytochrome P450, and everyone else is what? Is cell wall. So let's look at viruses, okay? And this is apropos to what's going on now, because there's so much silliness in the media, and people crack me up. My people, I mean laypersons. You know what? I only even include medical personnel, because there's some medical personnel saying some really wacky things. We just had a meeting for COVID, and the non-clinical people were saying some really wacky things about the antivirus and stuff. But me as a clinical person, I just keep my mouth shut. If someone wants to believe craziness, that's their issue. But let's not believe in craziness. Let's believe in what we actually know, right? Viruses are a minute infectious agent. If you recall your anatomy and physiology, let's say this this one box is the size of a typical bacteria. This dot here would be the size of a typical virus. And unfortunately, the Coronaviridae strain of viruses are one of the smaller ones. So if it's that small, again, I have to get it out there. It's going to go through everything. Now, it doesn't have any components of a cell wall. It acts like a parasite. It uses the host cell, either DNA or RNA, and utilizes the host cell's metabolic process. So if you had my lecture in anatomy and physiology, it's essentially a home invasion. You go in and you utilize everything on the inside. Now, let's say you are the police or the immune system. Do you see anything from the outside of the house? Nothing, because the virus is inside. It's actually not only inside the cell, it's inside the nucleus, taking over your DNA or RNA, which sends messages to the cell on what's the cell supposed to do. And the only message is, I need to make more virus, because it's a living thing, and a living thing needs to replicate. So there's no such thing as a good virus or a bad virus. It's just a thing that wants to live. Now, if you look at how viruses spread, you will now understand why, because we have distancing, why everything's closed down, because direct contact, contaminated food and water, inhalation of airborne particles, right? Exposure to contaminated body fluids and equipment. So essentially touching things, right? Or being exposed to things. And that's why they're telling everybody, don't go out as much, try not to be in large crowds. But and now the media is inventing these new words, like they're actually using those words wrong, like the word superinfection. That doesn't, what CNN is using as the word superinfection isn't what superinfection means, right? Superinfection means an infection on top of an infection. Like if I have a serious bacterial infection, it lowers my immune system, and then I could get a virus or a fungal infection on top of it. It doesn't mean like, what's the word they use? Super spreader, which makes absolutely no sense to me, right? Because look at all the big events of 2020, and let me point to you so you can do your own research. Look at the Sturgis motorcycle event that had 240,000 people. Most of them didn't want to wear their masks just so they could say they didn't wear their masks. I have some good friends of mine, because I used to be in the film industry when I was in college as a way to make some extra money. An entire film crew of 8, they were showing me footage. No one was wearing a mask. The bars were full. They also had the footage of those Antifa people. There was a small mini riot there. Um, the Department of Health and what do you call it? All the powers that be, they can't find any point source. Meaning to say is the virus didn't spread. But look it up yourself. So that it begs the question: there has to be some other modality, and we already learned that viruses and funguses they affect immunocompromised people, right? So because that is of considerable mention when you're looking at your patient. You have to ask your patient if they're very young or they're very old, they're potentially immunocompromised. If they have a diagnosis that's severe, like cancer or lower respiratory tract infection, right? That will lower their immune system. If your patient is experiencing considerable stress, even emotional stress, they are immunocompromised, and they can get viral infections. And if you recall my anatomy and physiology, COVID isn't the only virus that can kill you. By the way, influenza A in 2020 killed 240,000 people. But the news about COVID outweighed that, right? So something to think about when you're looking at data, when you're looking at the news, because that affects how your patient views a lot of your therapy and views you as a medical professional. So how do we block viral division? Well, there are some viruses. We already know that the viruses hijack the DNA and RNA. So that's one thing that we can do. We can have something that that goes inside our nucleus and does what? Just blocks the message that to make more viruses. And it doesn't really kill the viruses, but it stops it from dividing, which is a common, it's a common strategy in HIV. We can't kill it, but we can stop it from spreading, right? And you can look at it kind of like the way you have bactericidal medication and bacteriostatic medication. So that's one strategy, okay? And I mentioned influenza, hepatitis 2, right? And HIV. In the bloodborne pathogens, hepatitis and HIV, big thing. And once you get these two things, you already become immunocompromised. Your immune system already becomes damaged, and you lower your shields, and then you can get even sicker with what they call a super infection, another infection on top of the infection that you already have. You could have acute, chronic, and many times it goes for something like HIV, it's progressive. Meaning to say is it will keep on going until you die. But we have strategies to slow down its progression. A classic example, if you look at Magic Johnson, he's very well because of the medical cocktail. I have one nephew and one cousin who are HIV positive. They've both been HIV positive over 10 years because we were able to deal with the progressive and chronic effects. And you know what one of the greatest strategies is they both of them now lead very healthy lives. They don't drink, they don't smoke anymore, both of them. They're Garais, so they have to drink and smoke, but they don't do that anymore because they know that that could lower their immune system. My cousin Bal used to never work out. He was one of those people who are just naturally skinny. Now he's a gym rat. He's been a gym rat for 10 years because he knows that keeping your emotions positive and keeping yourself moving despite the lockdown will keep your immune system up. And again, look at the data on HIV and immunocompromised patients. Not a lot of them are getting COVID, which is an odd thing to me. Hopefully that doesn't change. Now, virus latency. Remember I told you it was like having a viral infection. It's like having a home invasion. So it's going to take some time for the virus to get inside and to replicate and to do some damage. And that's why you're going to have like a latency. Like you can be infected on day one, but it won't show any effects on any testing for like 120 days. Now, here was the also thing that I had inquiry about regarding COVID. So they're saying exposure time is 14 days, but I'm like, okay, I need to see data on that. And then, well, but it's kind of starting to look like it's 14 days, but I don't know, especially for the more serious cases. And HIV definitely, it could be almost 90 days until you have your first positive HIV test. And unfortunately, I know how that feels. I'm beg my forgiveness if you already had me for anatomy and physiology, and I gave you a Julio and Nelson story. Julio was my partner when I was in EMS, and both of us tackled a homeless man who was covered in blood in our street clothes. Very, very stupid. And he was HIV positive, and both of us got exposure to HIV. So for guess what? For the next 6 months, we had to be regularly tested for HIV. And we had to take the AZT cocktail just to make sure that we weren't HIV positive. One of the scariest, it was one of the scariest years of my life. And it's because I didn't follow the rules. Because if it is not your job to tackle patients, then do not do so. Because if you're not gloved up, masked up, and in your professional clothing, do not do work, right? And if that is not your patient, do not touch them. What should we have done? We should have just backed up, let security, let the nurses handle it, right? Instead, we wanted to be Batman and Robin. We wanted to be heroes. Instead, we were a precautionary tale to the rest of the emergency medical system. Like, don't be a jerk. Don't be stupid, right? And again, back to, right here. If you know how they spread, then because you know how to decrease the exposure, okay? So virus and cell interaction, we already mentioned it. They alter the cell by incorporating their genetic material. It either could be DNA or RNA. And DNA, of course, is the blueprint of who you are. So if I mess with the blueprint of who you are, instead of the heart cell becoming a heart cell, it'll become a virus factory. And the RNA was kind of like the go-between or the messenger between the DNA, the blueprint, and your ribosomes that made proteins. So if like, for example, the virus infects your RNA, then it will tell the message, instead of the message, hey, be a heart cell, the message now is make more viruses, okay? Now, even though the viruses have antigens, right? And they could have antibodies and immunoglobulins. Remember, in order for your immune system to quote unquote see the virus chemically, and also the virus is very, very small, it has to be outside the cell. But remember I mentioned this home invasion analogy. It's inside the cell. So the immune system can't get in there. And then it goes inside the nucleus and does all sorts of damage. And that's the real reason why we can't kill the virus. That's why for 70 years, we cannot kill the common cold. Fortunately for us, the common cold, which is also a coronaviridae strain, right? If you have a good immune system, it should kill your stuff within 7 to 10 days. Most common colds are what they call self-limiting. They'll take care of themselves. But as we now seen, what if we get a virus that doesn't take care of itself, like COVID, like respiratory syncytial virus, like influenza A, right? They go in, they do massive amounts of damage, and they don't go away, and then you get sick and then potentially can die. So we have antivirals. One kind of antiviral is, and we already know that it will block the replication without interfering the host's function. So it only blocks the viral DNA and RNA. It doesn't block the host DNA and RNA. And that's the main mechanism of action for antivirals and the main mechanism of action for anti-HIV medication and the HIV cocktail, also known as AZT. Okay, and it helps your body also, right? If it interferons, if you recall, those were the chemical signals that allow your antigen presenting cells to tell your body like, hey, over here, here's the bad guy, go kill this thing. So here's some, what do you call that? Systemic agents. And you could see here in the name, Vir, right? For Zovirax. So you'll have a lot of Vir. Even here in the, what do you call that? In the proprietary name or the brand name, right? Virazole. So use that for a kind of hint. And if and for my exam, I'll put both the generic and the what do you call that? The generic and the proprietary name. And also I'll make sure that it's something that'll give you a hint. But in the long run, it's best to, you really should memorize these when you start working. What kind of, other than HIV, that you can get, that you will need an antiviral? Well, you can get cytomegalovirus retinitis. You can also have herpes, that's a virus. Herpes zoster, also known as shingles, right? Influenza prophylaxis, right? We have an antiviral for influenza A, right? And of course, varicella, chickenpox, okay? And remember, herpes is the gift that keeps on giving. You have type 1 and type 2. Type 1 is the oral, type 2 is the genital. You can figure out how type 1 and type 2, how type 1 turns into type 2. We're all adults here. We have HBO, right? But you need a antiviral to deal with that. And herpes is very, very painful because that particular virus loves nerves. And, you know, nerves can transmit pain. And so herpes is very, very painful. Foscarnet, nice for CMV, you know, nice to know stuff. Amantadine, this is nice. Simitrel, this is the prophylaxis and treatment of influenza A. This is that we like promoting that, especially with our older population, because it is used for influenza A. And like I said, influenza A in 2019, I think, 2019, I quoted 2019, killed 240,000 people. That's why in the beginning, in the first couple of months of COVID, I was like, okay, it killed a couple of hundred. I'm not impressed yet. Even at 400,000, you have to look at the number. I know that's a horrible way to look at it, but if you look at it from a pure epidemiologic format, I actually have exercises when I used to teach HCA 402, which is epidemiology, exercises to show you how, if something is significant or not. And if you plug in the numbers, that's why I can't wait until teach epidemiology, and I'm going to revamp a lot of the stuff to push it towards COVID. You could see how a lot of places in the world, it's not really considered significant. But, you know, as long as it keeps on killing people, it's going to stay significant until we start focusing on the next thing that kills people. But I'm from the world of internal medicine. Diabetes and unchecked diabetes and hypertension are killing way more people, right? And the disparity between low income patients for diabetes mellitus and hypertension is staggering. It's in the millions, and it's killing people in the millions. But again, once this COVID thing goes again, hopefully we'll start focusing on that as well. Okay, so Amantadine, Symmetril, prophylaxis and treatment of influenza A. It's nice. Zovirax, acyclovir, very popular with herpes, right? I used to give this out when I was an outpatient, like it was chiclets. If now I'm aging myself. If you guys remember chiclets, it's candy in the 70s. Famvir, herpes zoster, which is shingles. Now you get these really, really bad dermatic lesions on your back, and they run like they kind of make you look like a Douglas fir tree in the back, and they're called shingles. They're very, very painful. And the precursor to shingles is if you've had chickenpox when you were younger. Because if you've had chickenpox when you're younger, right, it makes you a little bit immunocompromised. You still have what they call viral load. There's some virus still hanging around, and then it changes. The phenotype will then change to herpes zoster, also known as shingles. Ganciclovir, good for CMV. For many, it'll be a warning label as well. Make sure to check your hydration status of your patient if they're on ganciclovir or Foscarnet. But you'll see it on the label. Tamiflu, another prophylaxis for both A and B, right? And it's better with food. But Tamiflu, the data that I recall for Tamiflu, it's not too hot, but it's nice to have. Ribavirin, this is we use for ET tubes, right? And for respiratory syncytial virus. Say that 5 times fast, okay? And you see children, RSV in kids, wow, it's a killer. If I have a child with influenza, I have concerns. I have a child with RSV, that child's going to ICU. And they're usually very symptomatic. Influenza prophylaxis, Remantadine, it's nice, but the amantadine here is first choice. And if they can't tolerate that, we give them this. Valtrex, ooh, very good. It's what they call a prodrug. That means it goes into your body one way and then it changes into something else. So valacyclovir, and then your body then metabolizes it to acyclovir. And Valtrex, we love it for herpes and especially for immunocompromised patients. Zanamivir, nice, never used it. Ganciclovir, for ophtha antiviral. And if you have ophthalmic antiviral stuff, that means one or two things. You're either severely immunocompromised or you're touching things that you shouldn't be touching. Now, HIV. I've been rattling on all this time, so I'm gonna. Are you guys good? Any questions thus far? And you know how I can ramble on. If there's anything you want me to go back, and notice how I'm lecturing. If I'm going, yeah, nice to know. If I'm glossing over it, what are the odds it's going to be on an exam? But if I keep on going back to something like HIV and keep on mentioning things like that influenza A prophylaxis, like RSV, that's a good high-valued target versus something like ganciclovir. HIV and AIDS. HIV is it's a retrovirus. So what does it do? It hijacks the RNA of the host, right? And then that RNA, right, then it creeps back using this enzyme called reverse transcriptase, right? And it works its way back the process from the message, which is the RNA, to the actual DNA. So hijacks the RNA, then hijacks the DNA, using this enzyme called reverse transcriptase, right? Which is a retroviral enzyme. And that's how you get HIV into your DNA. And then the DNA now states that, hey, we're not going to make any more immune system like your CD4 cells, your T helper cells. HIV loves attacking the genetics of T helper cell. So now there's no more T helper cells to serve as an antigen presenting cell for your T killers. Remember, your T cytotoxic. So now there's just what? A whole bunch of HIV machines. And that's how insidious and how dangerous HIV is. So what did we use? We have drugs like NRTIs and NRTIs. All they do is do what? These three classifications of drugs right here attack the retroviral scheme, right? So nucleoside reverse transcriptase inhibitors, so it will block reverse transcriptase. Now, it's not going to kill the virus, but what's it going to do? It's going to stop the message for the virus to multiply. And that's how Magic Johnson and my cousins and my nephew can live so long and live a very, very fruitful life. And do you see it's all inhibitors? It also, remember your chemokines from anatomy and physiology? Those were the chemicals that promote, what do you call that? Your immune process, right? So it goes, if I tell the immune process and I hop onto the receptor to ramp itself up, what will it do? It will fight HIV. We also have protease inhibitors, right? Protease is something that breaks down proteins, right? That's what reverse transcriptase does. So if I have a drug that messes with the proteases that helps this transcriptase, then we're going to block HIV. So don't really have to memorize the 7 classifications of antiviral drugs, but know the main mechanism of action of these anti-HIV drugs. Its main action is to do what? Block this reverse transcriptase, block this enzyme and everything related to these enzymes. So let's see some examples. And like I said, if you look at a lot of the words, there's going to be some sort of viral in it, right? Like Epivir, and here's another one. There's a giveaway: Vudine, Zidovudine, which is AZT, or also known as Retrovir, right? This AZT plus there's a cocktail of 3 different medications with AZT. They will all block what? The reverse transcriptase enzyme. So Videx, really popular, Epivir, really popular, but the #1 HIV medication that all HIV patients have to be on is Zidovudine, which is AZT, also known as Retrovir. GI distress is common. That's another thing. My cousin Baal, he said when he first started taking the meds, because I said, how is it? He was like, and he goes, I'm going to the bathroom like every 30 minutes, man, and it's killing me. You know what he did to survive it all? He forced himself to eat. And guess what? Right? You have to take these meds on an empty stomach because this what happens. But you know what he did so he can try to stay healthy and live through at least the first year of some serious side effects? He physically forced himself to eat. No matter how many times he had any of the GI symptoms, he said, I just forced myself to eat. And whatever, you link on whatever motivation that your patient has. For example, me and Baal, we've been smoking since we were 12. And he's when he was diagnosed, he was in his mid-40s, and he's a single parent. He has a baby girl. And I told him, you got to live, because he goes, you got to live for that baby girl. And it goes, and now about 10, 15 years later, right? He got to watch her graduate. He got to do all of that because knuckled up, did what he had to do, right? So all of these drugs, right? Remember, How many times did I say this? 3 times? It attacks reverse transcriptase. Right? So that's the theme here. Okay? Prevent formation of DNA copy. Right? You see viral, right? For the NNRTIs, right? Vir, right? Okay. Protease inhibitors. HIV protein precursors that need to replicate the virus because proteins build things, right? Well, there's certain proteins that build HIV, and the protease inhibitors attack that, okay? And again, you know, nice to know. What's really, really important other than, again, labels. Pay attention to your labels. When you, because even now, even for something as basic as, you know, a basic antibiotic, I'm always constantly reading the labels just to make sure. And another thing that they're always doing in medicine is they're having updates all the time. And that's why we're going to, shortly, I'm going to hit up some of the updates for HIV. All right. So post-exposure prophylaxis, that's why when I told you when me and Julio, we got exposure. Actually, it was within not even 30 minutes. We were asked to strip. Then we were in a, you know, the emergency showers. We had to scrub down, and then we were all given the AZT cocktail within 30 minutes. Because if you have exposure, the AZT cocktail, once it goes, if prescribed within 2 hours, it can decrease the risk of infection of 80%, which is serious. That's really neat. So, but how's this? The best way to do it is listen to the rules, always be careful, glove up all the time, right? Have your bloodborne pathogen universal precautions that we went over in your clinical classes. That's really important, okay? These are combos, but again, with the advent of electronic medical records, if the physician or the nurse prescribes what do you call that, bad combinations, it'll flag it, and you won't, and the pharmacist won't be able to fill the prescription. Okay, now combining antiretrovirals, right? That is a classic a classic strategy for HIV. Like I told you, AZT is a single drug, but it comes in a cocktail form with 2 other drugs, right? And now it's at this point. Where is? Oh, did I get kicked out? I got kicked out. Let me check attendance. There's a whole 2 of you. Let me write down who was here. Where are we? Here, 240. And remember what's due today. Please, please, please get out that the study questions for week 3 and your discussion 3. So let's look at this HIV drug therapy update. And you know what? Let's not take that HIV quiz, update quiz. You don't need that. Just take 1 quiz this week. You know, you got an exam too. So you have a antiviral quiz, and so let's look at the HIV drug therapy updates. Okay. We already went through that. We went through that. It's the same thing. Not much. No, here's new. fusion inhibitors, CCR5, and integrase inhibitors. But if you see, it's the same thing, isn't it? Right? Blocks the fusion of HIV to the CD4 cell, right? Maybe you guys remember some of my research when I was an undergraduate, when I was in your seat. My research dealt with the affinity or how sticky prostate cancer cells were to the prostate cell. Well, somebody in the last 10 years has been working on this. We know that the HIV adheres to a CD4 cell, right? The T helper cell. So it adheres to it and has to stick to it. It's sticky. So they found out how it gets sticky and then inhibits it. So that's pretty smart. So that's what an infusion inhibitor does. Look at this, CCR5, right? It messed with the receptor, the HIV receptor that allows it to go inside the CD4 cell. So if I block that receptor, CD4 can't go inside the HIV can't go inside the CD4 cell. That's pretty freaking ingenious. So fusion inhibitors, CCR5 inhibitors, and just like protease inhibitors, it has an integrase inhibitor, right? So it can't integrate, HIV cannot integrate itself into the host nucleus. So it's in there, but it can't stick to anything. So that's Dr. Cisco's latest updates. That's pretty smart stuff. But when you look at it all, isn't it all the same concept? Prevent HIV from replicating. That's the main mechanism of action. That's what a protease inhibitor does, fusion inhibitor, CCR5 inhibitor, integrase inhibitor. Nice, right? Okay, so that's Dr. Cisco's updates. That's pretty freaking cool, right? It's nice to know that the world is changing. Because to be honest with you, I've never heard of those drugs before. I'm still old school 1980s AZT guy. By the way, AZT's been around since then, since like early 90s. Handout, HIV drug therapy. Let me see. Let's see what this handout. Oh, it's the same thing. Okay, so it is at this time of the show, right? I will stop the recording.